Hello, everyone. Here is acute kidney injury presented by the internal medicine chiefs. You are likely to see many acute kidney injuries during your time on hospital medicine, so we hope that this brief overview will be helpful for you. To begin, what is an AKI? Nearly everyone defines this according to the 2012 KDIGO criteria, which are in the process of being updated, but for the time being, these are your possible definitions. Increase in serum creatinine greater than 0.3 milligrams per deciliter within 48 hours, increase in serum creatinine to 1.5 times baseline or greater within the past 7 days, or urine volume less than 0.5 mils per kilo per hour for 6 hours. I have had an attending dismiss the 0.3 in a patient who had a really high baseline creatinine, so like a 3.5 to a 3.8. They didn't get that excited about that. I didn't see anything ruling out this criterion in someone with advanced CKD, but you may run into that, just so that you're aware. Once you've diagnosed an AKI, you need to stage it. Increased stage is associated with increased risk of complications, including need for renal replacement therapy. I don't think you're super likely to get asked about stages as a third-year student. However, if you have the time and mental capacity to commit these things to memory, or at least reference this table when you diagnose a new AKI, could be very helpful, could be a way to impress your team as well. So then we need to think about, where did the AKI come from? The three buckets that we put AKIs into are pre-renal, intrinsic renal, and post-renal, as you know well. Post-renal is the simplest. It's just an occlusion after the kidney, usually in the ureteropelvic junction or at the bladder. Pre-renal and intrinsic renal are a little bit harder to tell apart, and the best way that I know to do it is to think about the fact that in an intrinsic renal acute kidney injury, the tubules are no longer able to reabsorb solutes like they typically can. But in pre-renal, they can reabsorb solutes. It's just that not enough blood is actually reaching the kidney for the kidney to fully clear out the blood like it's supposed to. And so when we think about the lab tests that we use to differentiate them, I find that thinking of it in terms of tubular function is a really helpful way to remember. So if we go to pre-renal acute kidney injury, remember that the kidney itself, which is supposed to reabsorb sodium, still works. And so you would get a normal urine sodium concentration of less than 20 milliequivalents per liter, and a normal FeNA of less than 1%. The BU to creatinine ratio is typically quite high in this situation, usually over 20. I will mention that the BU to creatinine and FeNA are imperfect per AMBOSS, but you will still see them used, especially on step 2 and possibly in clinical practice as well. Causes are any reason the kidney might not be getting perfused: hypovolemia, shock, low effective arterial blood volume, simply meaning that you have plenty of volume but it's not in the arteries for one reason or another, cardiorenal syndrome from heart failure being common, or the patient is taking drugs that decrease renal perfusion. So the management is fluids, unless they're having cardiorenal syndrome. If they're having hepatorenal syndrome, you can give them, but that won't help. And then you need to get the patient off of any drugs that will decrease their perfusion. If we move on to intrinsic renal, then we're looking at increased sodium in the urine because the tubules are not reabsorbing the sodium like they are typically supposed to. The BU to creatinine ratio is going to be lower, typically less than 15, and this has a huge differential which you can look up when you're making the diagnosis. Most common is acute tubular necrosis, often just because of a long-term pre-renal injury building up, and eventually you get tubular necrosis. And that will cause oliguria and all these things that you learned last year. Can be acute interstitial nephritis, contrast nephropathy, glomerulonephritis. And the management of this is very cause specific. For example, in acute interstitial nephritis or vascular, like vasculitis, you'll give them steroids. That doesn't help in acute tubular necrosis, so you have to figure out the cause. You always want to be thinking about nephrotoxic drugs and whether you can discontinue them. Two classic acute tubular necrosis drugs are aminoglycosides and platinum chemotherapy like cisplatin. And then post-renal, like I said, just look for obstructions, typically at the ureters or the bladder. You can always check whether the catheter is occluded. This does not have an obvious lab presentation. Last thing I want to mention is cardiorenal syndrome types. I got asked about this when I was on hospital med. Type 1 is acute cardiac failure causing renal failure. That's the most common. Type 2 is chronic cardiac failure causing chronic renal failure. Type 3 is acute renal failure causing cardiac failure. Type 4 is chronic renal failure causing cardiac failure. And type 5, if you want to think about it that way, is a systemic disease which causes both cardiac and renal failure, cirrhosis being a common example. If you're interested in further reading, please check out these links, especially the top one. And I've also created a small, quick Anki deck if you're interested in using that to commit some of these basics to memory. It's split into essentials and extras, and so feel free to check that out as well. Hope this was helpful.